everyone, this is our presentation. We will be discussing the vocal tract and the different instrumentation used for measuring, evaluating, and treating.
What is the vocal tract? The vocal tract is known as a physical system that starts from the end of the vocal folds and goes all the way to the edge of the lips. This physical system includes the buccal, nasal, oral, and pharyngeal cavities. The vocal tract is like a resonator and filter for the sound that are produced by the vocal folds. Our vocal tract is responsible for how sound is perceived because it can always change its size and shape. Our lips can change the length of the vocal tract, changing the pitch of the sound being produced. The tongue's position in the mouth affects the production of different vowels and consonants. The pharynx changes our vocal tract by making the vocal tract larger when it is open, allowing for the pitch of sound to be lower. And when the pharynx is contracted, the pitch of sound is higher. The larynx houses our vocal folds, which allow for the passage of air and production of sound. Acoustically, when the jaw drops, the vocal tract is shorter. And when producing speech, our soft palate also changes by dropping up and down to freely create different vowels and consonants. All of the structures stated above compose the vocal tract. What is instrumentations that measure the vocal tract? High technology has become accessible and has been growing in the field of speech pathology. There are far too many different types of instruments that can be used to measure voice, such as vocal tract imagers like radiography, video fluoroscopy, MRI, electromyography, and so many more. We are privileged to be living in such a time where we are able to see beyond what the naked eye can see and visualize our vocal tract functions through instrumentation that is able to measure movement, speed, and articulation inside of our bodies. Instrumentation is widely used in medicine, and it is not different in the field of speech pathology. Instruments allow us to study, analyze, and diagnose patients through the use of high technology. How is the vocal tract and instrumentation for measuring relevant in the field of speech-language pathology? The vocal tract is of extreme value to speech-language pathologists. Without the vocal tract, the production of voice would be impossible. The vocal tract is home to so many important structures that play a vital role in the production of voice and speech. The development of our vocal system has given us the ability to develop as humans and within our cultures. Speech pathologists analyze and study the vocal tract every day in order to come up with different approaches to help individuals who may be struggling with various different types of speech delays or disorders. Speech pathologists also work in medical settings, helping individuals who may be struggling with things like dysphagia. The vocal tract is the primary location of study, and because sound travels through the vocal tract, this area needs to be thoroughly studied in the field of communication sciences and disorders. Instrumentation for measuring the vocal tract is also relevant in this field because it allows speech pathologists and voice scientists to have greater and more in-depth accessibility to the areas in our bodies that cannot be seen without special instrumentation. For example, movement of the tongue is extremely important for proper pronunciation of vowels and consonants. And a speech pathologist cannot get a good look at positioning and articulation of the tongue without a device that would allow them to see inside of the mouth while the patient is speaking. In today's world, an ultrasound would give us that access.
So there are a lot of different instrumentations that can be used to measure the vocal tract, but for the clinical piece, I wanted to focus on how ultrasounds could be used on the vocal tract and how that applies to a clinical speech setting. So I found an article that was published by the Cleveland Clinic, and it's about basically how the R sound can be remediated through the use of ultrasound in a speech therapy setting. So the R sound is one of the hardest phonemes for a child to master due to complex tongue positioning with no good landmarks and there being various ways one can produce the sound. So the Cleveland Clinic SLPs began taking advantage of ultrasound technology to remediate articulation disorders in patients such as this articulation of the R sound. The SLP would utilize an ultrasound probe plugged into the computer in order to display a visual image of the patient's oral cavity. The SLP first uses the probe under their own chin to model correct articulation of the sounds, including R, or, air, ear, ire, in the R sound. The probe is then used on the patient where they can attempt to imitate these sounds while watching their tongue movement. Lisa Leonard, the inpatient therapy clinical manager SLP at Cleveland Clinic, attempted ultrasound use on a 10-year-old girl for the first time and found swift results when it came to learning how to properly pronounce the R sound. Rather than taking months to learn how to articulate the R sound and use it in words, followed by phrases, and then finally sentences, with the use of ultrasound technology, the child was able to correctly articulate the R sound within a handful of sessions, and she began implementing it into her speech rapidly. Leonard feels that it's not too late to begin implementing ultrasound use into speech therapy for teens who are unable to grasp the concept of difficult articulations through regular speech therapy when they were young. She says that they may not have had the advantage of ultrasound in the past, so it may be worth a try now if the patient is motivated. So we know that the R sound is a very difficult phoneme to learn how to pronounce correctly, and it's even one of the last sounds that children learn how to say. So for children who are already experiencing articulation impairments, the use of ultrasound technology can be extremely beneficial to them after going through months of traditional speech therapy and seeing little to no improvements. So the Cleveland Clinic article emphasizes the fact that it's not too late for adolescents to go back and begin using this ultrasound therapy to help remediate the sounds that they were never able to grasp the concept of during traditional speech therapy when they were young. So this is very important because speech remediation through the use of ultrasound therapy can be used for both children and adolescents to help prevent peer ridicule due to speech impairments that might otherwise be there. To supplement the Cleveland Clinic article, I found a peer-reviewed study on the remediation of the R sound using ultrasound technology. It was a study that was conducted in 2005 using 2 English-speaking participants who had not acquired the R pronunciation yet. The study encompassed an acoustic analysis and ultrasound imaging of the participants before treatment and again after 13 one-hour-long sessions using ultrasound therapy. After the sessions were complete, 3 speech pathologists who did not know the patients evaluated them and found significant improvements to the R pronunciation in words and phrases. And they also found that the patients' tongue placements were much more similar to typical adults when they completed their post-treatment ultrasound imaging. The study concluded that ultrasound imaging technology does have a place in speech therapy for the remediation of the R in speakers with articulation issues surrounding the R phoneme.
Clinical piece, journal article, predicting singers' vocal fold length and voice classification by using X-ray. In order to better understand vocal tract length, the University of Music Dresden, Germany allowed students who were admitted since 1959 had to have physical examination to view voice function. The examination used X-ray profiles to view the singer's vocal tract and determine if different laryngeal morphological measures influenced the vocal fold length. The study also measured if anatomical differences among singers had effect on voice classification. X-rays results are used for measurement of vocal fold length, most of which were used during phonation, which is
which is to understand that the vocal fold length varies with fundamental frequencies in phonation. Measuring vocal fold during phonation is difficult because high fundamental frequencies are produced with long vocal folds. The examination focused on different aspects of the singing voice and conducted assessments done by phonometricians, logopedists, and singing teachers. The data collected was done on at least 340 individuals despite the protocol changes. The data collected evaluated different aspects such as voice pitch range, mean speaking pitch, neck circumstance, body weight, and weight. Furthermore, from 1959 to 1991, the X-ray machine helped see students' upper airways, mostly entire vocal tract, and images were taken with X-rays during tidal breathing. This data was then used in present investigation to find relations between the experts' classification of singer voice and laryngeal measures. The question being asked was whether there is an anatomical difference between singers of different voice classifications. The Desjardins X-ray material was used for the present study, except for a few individuals not meeting the criteria. The material consisted of 132 individuals, 71 females, and 61 males. The data showed that TS and STAP distances X-ray morphological measures correlated with vocal fold length. The results revealed a clear correlation between predicted vocal fold length and voice classification. This supports the assumption that there are consistent anatomical differences between singers of different voice classifications.
As we've learned, instrumentation and measurement is incredibly crucial to assess the vocal tract. Vocal tract visualization and images utilizes a collection of procedures for performing examination of the vocal tract and gross function, including vocal fold vibration. A few other examples of instruments used are flexible fiber optic nasendoscopy, or FFN, and video stroboscopy. FFN is performed using a nasendoscope, which is inserted through the nasal passage. A fiber optic bundle then transmits high-intensity light, allowing the structures to be illuminated, which are then recorded in view. Through this use of instrumentation, it provides great images of the vocal folds and velopharyngeal structures, especially during voicing, singing, eating, swallowing, and rest breathing. This is incredibly important to see if a child or a patient is eating correctly or if they have any abnormalities in their vocal tract. Video stroboscopy utilizes an endoscope combined with a strobe light correlated to vocal fold vibration via a laryngeal microphone. With the combination of both, it permits the vocal tract structures to be seen in a slow motion format. Its advantages provide information relative to the effect of pathology on the process of voicing. Stroboscopy allows for various features to be assessed, like the periodicity of the vocal fold movement, whether they are always, sometimes, or never periodic. Vocal fold appearance, which is important to note of any pathologies or abnormal growth. Secretions can also be observed in the amount of consistency made in the vocal tract. With interpretation of these images, one can observe whether the voice quality and larynx are abnormal, normal, whether they're functioning as they should be, and also observe functions of the velopharynx and its degree of closure as well as its behaviors. These following procedures allows one to assess any abnormalities or disorders which are seen within the vocal tract, and for speech pathologists to assess and make treatment plans that a patient could then benefit from, including plans for voicing, deglutition, or resonance disorders.
All of the previously stated instrumentation can help clinicians evaluate the current functioning of the vocal tract, as well as provide understanding of some of the problem areas that patients are struggling with to help develop treatment plans and then even to carry out the treatments. Biofeedback is a great method in which participants or clients can help be a main participant in their treatment themselves. And this can be seen in the Cleveland Clinic study that was mentioned earlier on the R sound remediation. And this used ultrasound biofeedback, where the patient was able to see their tongue in the ultrasound and make changes necessary to make that R sound. Another study by Bruner and colleagues in 2005 used nasopharyngoscopic biofeedback methodology, in which a small tube was inserted through the nose and was able to view the back of the throat, in which the velopharyngeal port is located. And this port is responsible for opening the passageway into the nasal cavity, and when air goes through the nasal cavity, sounds have a more nasal quality to them. And so this biofeedback helped patients with cleft palate learn how to close their velopharyngeal port, because sometimes it remains open and they have a hard time closing it, and therefore they have sounds that have a nasal quality when they aren't supposed to. And so by viewing the screen that showed the back of their throat in real time, they were better able to close their velopharyngeal port and therefore reduce the nasality of certain consonant production. Not only are instruments that measure the structure of the vocal tract useful, but we may also be interested in how the shape of the vocal tract may be changed to alter the sound resonance and other vocal tract acoustics. Some clients may present with problems that occur during phonation and speaking that cause them to produce sounds incorrectly, and they might want to be able to fix that. And so various tools, even tools that we see in our daily life, can help when it comes to treatment, especially with biofeedback. So microphones and speakers can be employed to help patients hear their own voices and make adjustments towards some goal. And that's exactly what a study by Graf and her colleagues did in 2020. It demonstrated how biofeedback that used microphones and speakers was able to help non-professional singers alter their vocal tract shape in order to produce some target resonance. And they were even successful with adjusting their vocal tract without voicing. And that also allowed them to be able to produce voice sounds correctly. This can have many applications and many forms of treatments. This idea of feedback when it comes to real time, seeing how changes of your vocal tract alter sounds that you make. And so this can be implicated and used in many, many different forms of treatment, not only for voicing, but for speech in general.
Research findings. Using a light source alongside vocal tract imaging was first reported by Manuel Garcia in 1855. Then in 1895, Ortel used a stroboscopic light source with a laryngeal mirror to be able to examine a slow-motion visual of the vocal folds through the pitch range. Since then, research has signified the importance of video endoscopy for a more accurate diagnosis of voice disorders. Then in 1968, Lubker used cineradiography and electromyography to examine levator muscle use in speech. Then in 1969, Sudolny, Kaw, and McCormick found some seminal information about a normal bilabial stop and the nasal consonant production using cineradiographic and aerodynamic techniques. Matsui, Miyazaki, and Yamaoka in 1974 used endoscopic images to learn about the motor innervation of the velopharyngeal aspects. Then in 1975, Bell, Birdie, and Hirosh used the endoscopy and electromyography approach to show the activity of the palate during normal voice and unvoiced consonant productions. In 1979, Glasser, Sholnick, McWilliams, and Sprinston all discussed in detail about the activity of passivants ridge in normal speakers and those with voice disorders. Croft, Sprinston, and Rakoff in 1981 describes some major patterns of velopharyngeal closure seen during speech. In 1968, Shelton and a few years later, Siegel, Seidwitz, and Springston successfully used the video endoscopic biofeedback therapy to improve velopharyngeal closure in hypernasal speakers. Then in 1987, Bless, Hudson, and Feeder noticed some parameters of the vocal fold vibration during a video stroboscopic evaluation during phonation. Carnell, Linville, and Edwards in 1988 described differences in velar position that usually occur during speech using the video endoscopic imaging.
As research has continued to progress, the instrumentation to measure, study, and analyze the vocal tract has advanced as well. A specific method of analyzing the vocal tract is with the use of MRIs as well as with ultrasounds. MRIs and ultrasounds are used often in speech studies and research as they offer a way, especially non-invasively, to view and measure the vocal tract. In January 2021, a research study was conducted by Ruthven, Mikal, and King using MRI two-dimensional scans to develop a new method of viewing the vocal tract by segmenting multiple groups of the vocal tract and the articulators. They were able to successfully develop this new automatic method, which is a positive step for research as it overcomes limitations of other existing methods. Other methods either only segment the ear tissue boundaries between the vocal tract and neighboring tissues, or they only fully segment the vocal tract. This new method fully segments images of both the vocal tract and the articulators. In July 2022, another speech research study was conducted using ultrasounds to provide speech-language pathologists with visual biofeedback of the vocal tract and tongue shape during speech production. The purpose of this research was to see if providing speech-language pathologists with visual biofeedback training so that they have the skills for assessing tongue movement and positions, they can then apply those skills to correct speech sound errors in clients and patients. The research study showed that using visual biofeedback for analysis and treatment is highly effective. As instrumentation continues to advance and improve over time, the research findings will continue to enhance researchers' ability to better understand the vocal tract, articulators, and speech.
Summary. The vocal tract is a physical system that includes the buccal, nasal, oral, and pharyngeal cavities. It is like a resonator and filter for the sounds that are produced by the vocal folds and is home to sound production. Instrumentation for measuring the vocal tract is relevant in this field because it allows speech pathologists and voice scientists to have greater and more in-depth accessibility to the areas in our bodies that cannot be seen without special instrumentation. Various instrumentation can be used to evaluate the vocal tract and treat any disorders or problems. Such instruments include flexible fiber optic nasendoscopy, video stroboscopy, nasopharyngeoscopy, ultrasound, and many more. Importantly, biofeedback from these instruments can help patients take control of their own treatment and improvement. Ultrasound technology has been proven to be a valuable tool within the clinical setting for patients undergoing articulation remediation due to it offering patients the ability to actually see what is going on inside their oral cavity during articulation. After watching the speech pathologist model the correct pronunciation, they are able to imitate the sound much easier. In order to find relations between experts' classification of singer voice and laryngeal measures, experimenters used data from a previous study by the University of Music, Dresden, Germany, that used physical examination to view singers' voice function to determine if different laryngeal morphological measures influence vocal fold length. The benefit of X-ray results allowed experimenters to see different singers' vocal fold lengths. The findings concluded that there is a clear covariation between vocal fold length and voice classification. Research on instrumentation for measuring the vocal tract has dated back to the mid-1800s. Since then, there have been many studies conducted on various methods of instrumentation throughout the century and even still improving to this day. As instrumentation available continues to advance and improve, the research conducted will continue to enhance researchers and speech pathologists' abilities to measure, evaluate, and treat.